All right, perfect. All right, good morning, everybody. I'm Abhi. I'm one of the PGY2's neurosurgery residents here at Mount Sinai. I'm going to be presenting today briefly on our pediatric brainstem tumors and just a brief overview on the different classification and management strategies for these tumors. And we're going to start off with a case of Dr. Morgenstern. This is a 70-year-old male with no past medical history presented with a headache waking him from sleep, as well as several episodes of vomiting and an unsteady gait that began 1 to 2 weeks ago and was getting worse. So the mom brought the patient to the emergency room, and the CT scan showed the following. All right. So, let's see. All right. So the CT scan shows, hydrocephalus. You can clearly see ventriculomegaly with enlargement of the lateral ventricles as well as the third ventricle. So this patient was transferred to Mount Sinai emergently and was taken to the operating room for an endoscopic third ventriculostomy. Of note, you can also see that the fourth cerebral aqueduct is stenosed, and there's some obstruction there, causing a non-communicating hydro. And here's a brief video of the ETB that was performed. You can see as we're going through the foramen of Monroe into the third ventricle. And there you can see the perforation. Yep. So fast forward this a little bit, and you can see now we have a nice little ETB draining the CSF, providing an alternative pathway. You can see the basilar, you can see the perforators as well. It's a really nice view. Post-operatively, patient did well, and patient got an MRI. And this is a T2. This is a sagittal T2 cube sequence, and you can see right here. You can see right here this this brisk flow of the cerebrospinal fluid going through the ETB site. It's a hyper intense on this sequence, and you can see the flow void right here. So, and the MRI is also notable for a tectal lesion. You can see it's a compressing the foramen of the cerebral aqueduct, causing the hydro. So we're going to start off with the central nervous system brainstem tumors for the pediatric patients. A little bit of an epidemiology. They consist of 10 to 20% of all the CNS tumor in children, and they generally do not have any gender preference. The most common ages are between 5 to 9 years of age, which is also the common age presentation to the hospital, except on some tumors where the patients would be symptomatic for a few years before they present. So the classification of these brainstem tumors is a little interesting because it's not always necessarily based on surgical finding, as a lot of them don't require surgical treatment. And so the initial classification is always based on MR imaging, and the histologic subtype has been pretty well predicted based on its a tumor's anatomical location in the brainstem, with a few caveats that we will go through. The 5 main subgroups include tectal tumors, diffuse intrinsic pontine glioma, focal tumors, dorsal exophytic tumors, and cervicomedullary tumors, based on their location and the way they look on the MRI imaging. A little thing is it's pretty difficult to identify some of the rare primitive neuroectodermal tumors or gangliogliomas solely based on the MRI. So they present a bit of a challenge and require further investigation. Next slide. All right, so we're going to start off with diffuse intrinsic pontine gliomas. These are very infiltrative tumors that arise from pons, and they, however, they may extend into the midbrain or the cerebellar peduncles. Initially, the kids present with focal neurological deficits, including cranial nerve abnormalities, as well as cerebellar dysfunction. The prognosis for these tumors is extremely poor, and unfortunately, the role of biopsy on this is very limited for investigational purposes, as well as for molecular marker studies. Most of these are treated with radiation, which is shown to improve progression-free survival, but it does not improve overall survival in these patients. There are some clinicians who differentiate between atypical presentation of a DIPG versus a typical presentation, and some argue that if it's an atypical DIPG, it can be diagnosed with solely based on the MRI and does require biopsy to confirm. However, there is variability among neurosurgeons on what is considered an atypical DIPG. Interestingly, regarding the biopsy, about 1 in 4 parents actually agree to biopsy, even though it would have clearly no benefit to their own child. And around 50% of parents are agreeing to biopsy if there's a minimal chance of benefit to their kid. Important thing to know is diffuse intrinsic pontine glioma also now falls under the umbrella term for diffuse midline gliomas based on the WHO purposes, WHO classification. And this is important because this typically means that there's a presence of a K27M mutation in these tumors, which could be targeted by molecular therapy. I think the most recent I found was histone deacetylase that is currently under clinical trial that could be therapeutic for these kids. The next segment is focal brainstem tumors. These could be located anywhere except ventral pons. These tumors are well demarcated compared to the other brainstem tumors, and by definition, they occupy less than 50% of the axial diameters of the brainstem. The pathologies can vary of these tumors. Most commonly they're pilocytic astrocytomas, WHO grade 1, and other low-grade gliomas. However, you could have ganglioglioma or high-grade gliomas in here. So since the classification is based on MRI, for the patients for the tumors that are not clearly characterized based on just MRI imaging as focal or diffused, one strategy is to perform a stereotactic biopsy and subsequently consider resection based on what the biopsy shows. Otherwise, for a lot of the well-demarcated lesion, the treatment could be surgical resection or radiation chemotherapy if the tumor is unresectable or challenging to resect. And generally, surgery is done, the resection is done for pilocytic astrocytoma, low-grade astrocytoma, or gangliogliomas. The next category is dorsal exophytic tumors. Their name is very self-explanatory. They're most commonly found in medulla, but they can also be found in pons or pontomedullary junction. You can see the MR imaging here. They're protruding dorsally into the fourth ventricle, and generally present with signs and symptoms of hydrocephalus, failure to thrive, and just headache and vomiting. Interesting things about these tumors is that the kids that present with dorsal exophytic tumors tend to have a longer symptom duration before presentation, before the diagnosis of these tumors, compared to the patients with other types of brainstem tumors. They do enhance on MRI with contrast, which helps helps distinguish them. Typically, they're low-grade WHO 1 or 2 astrocytomas or gangliogliomas, and the treatment for these tumors is surgical debulking and treatment for hydrocephalus. Generally an ETV initially, followed by a tumor debulking. And the goal of surgery for these patients is to debulk the tumor as much as possible, especially the exophytic component. But it can sometimes be challenging to resect the more anterior aspect of the tumor due to the proximity to brainstem. So the gross total resection is a lot of the times not possible. And so radiation is also used as an adjuvant for residual tumors after surgery. All right. So next subgroup is cervicomedullary tumors. These are fairly interesting because they behave fairly similar to upper cervical tumors that would otherwise be that would just be invading rostrally into the medulla. They behave similar to spinal cord astrocytomas. The interesting thing about these tumors is they can be classified into two major groups. Initially, the ones that start off from the cervical region and grow up rostrally into the medulla. These tumors tend to have distinct margin, and they basically get stopped by the long tracts, and they are fairly relatively easy to and amenable to surgical resection due to their good margins at the medullary level. However, on the other hand, there are some cervical medullary tumors that start from the medulla and they have a caudal extension. And that distinction is important because these tend to have a poor margin at the level of the medulla, and it's more infiltrative around the long tracts, and they're much more challenging to resect. They present with bulbar symptoms, focal neurological deficits of lower cranial nerves, and long tract signs such as abnormal reflexes, Babinski, Hoffman's hyperreflexia, and also spasticity. Most of these tumors are low-grade gliomas. Less frequently, you could have ganglioglioma, and I feel like you can get the trend that ganglioglioma is actually it's not the most frequent in any of this location, but it's always on the differential for any of these brainstem tumors, regardless of their location. The other would could be anaplastic astrocytoma or ependymoma, the former of which would be could be challenging to resect. And the treatment we talked about could be surgery based on if it's a cervical tumor extending up or a medullary tumor extending down, the latter of which would be more amenable to radiation and chemotherapy after a subtotal resection. The next one is a primitive neuroectodermal tumors, also known as PNET. These aren't very common, but they're fairly interesting because these are rare brainstem tumors that are well circumcised, that present as a well circumcised pontine tumors. They are not, they're obviously different from DIPGs in terms of their presentation and in terms of their prognosis. They actually they have an exophytic appearance on MRI, and they do not have a contrast enhancement, which makes them more easy to diagnose compared to their other counter PNETs that are found in the supratentorial region, or even in the which is mostly pineoblastoma would be the most common tumor presenting above the tentorium, but that would enhance with contrast compared to these ones. They can also have leptomeningeal spread and diffusion restriction, and the diffusion restriction is also a key to diagnosing these tumors in the brainstem because the DIPG is not likely to have a diffusion restriction compared to a PNET. The treatment for these tumors is you can do a biopsy to confirm the diagnosis and resection if possible. However, given the leptomeningeal spread, it's recommended to get an MRI of the spine as well, and the patient may need a craniospinal radiation. All right. The last but not least is the tumor that we initially saw in our presentation right here, a tectal mass, in a kid causing hydrocephalus, very commonly under the category of tectal tumors, or tectal gliomas, as we call it. So they encompass 5% of their brainstem 5% of total brainstem tumors in pediatric patients, and they tend to be very indolent and slow growing. And their presentation is basically what this kid had, generally hydrocephalus with before any neurological symptoms develop on these patients. On MR imaging, you can see thickened collicular plate like we saw, and they compress the cerebral aqueduct, and they generally do not enhance in contrast. However, there are some variations of these tumors that we're going to discuss in a few minutes. Typically, these tumors could be a low-grade astrocytoma, but rarely can also be ganglioglioma. And the treatment for these tumors is obviously we treat the hydrocephalus first, most of the time through the ETV, because there are studies that show that for tectal tumors presenting with hydrocephalus in a kid, there's an 80 to 100% of patients who, after undergoing ETV, will remain shunt-free with excellent control of the hydrocephalus. So for these tumors, biopsy is generally not indicated unless there's a significant tumor progression, which brings us to our next point after reviewing this MRI. So you can see on this MRI scan, you can see a tectal lesion that is non-contrast enhancing, that is compressing the cerebral aqueduct. So distinguishing these tumors from infiltrative pineal tumors, tectal tumors can have exophytic growth, which could infrequent, but it is possible to have an exophytic growth. However, their exophytic growth would more likely to involve thalamus as opposed to the pineal tumor, which would likely involve the quadrigeminal cistern when they grow extremely large. Other caveats to keep in mind is that even though the most likely most appropriate course of management is observation and just serial MRIs, there have been some studies that have linked the initial tumor size at diagnosis to the need for a future treatment, whether or not it would be biopsy or surgery or radiation. Some studies have shown that tumors greater than 10 centimeter cube in volume at presentation will ultimately require treatment down the line, as opposed to patients with tumors less than 4 centimeter cube, which would not require intervention. And even with the patients who have tumors that are fairly small, the tectal tumors, surveillance is still recommended, especially if these tumors seem a little bit not normal, if they seem to be enhancing on contrast and they're not typical MRI appearance of a tectal tumor, more routine MRI is recommended. A lot of these tumors can progress, and therefore can patients do undergo radiation chemotherapy or even subtotal resection with an adjuvant radiation after the resection. There were some studies that would argue they were arguing for biopsying every single one of these tectal tumors just because of the population of these tumors, which have a potential to become infiltrative and potential to have a significant enough growth to require treatment later in life. However, that is only true for tumors that don't have a typical presentation, and it doesn't seem that it's warranted to biopsy every single one of these patients, especially if they have a normal or a typical appearing tectal glioma. All right. So just a brief slide about prognosis. As many of you are aware that diffuse intrinsic pontine glioma are the ones that have extremely poor prognosis. 1 year survival could be as less than it's less than like 10 to 20%, and a 2-year survival for this kiddos is basically 10%. So there's still a lot of research going on in terms of molecular treatment with this histone markers that these tumors present. Other brainstem tumors tend to have overall better prognosis. However, they do depend on the histological diagnosis. So even though the classification doesn't solely depend on histology, their overall prognosis does depend. And with studies showing that, for pilocytic astrocytomas would have a 95% survival, 5-year survival, versus obviously if it's a fibrillary astrocytoma, you're going to have an 11% 1-year overall survival for these kids. And the most important prognostic factor for tumors other than DIPG is the extent of the initial resection, which is pretty similar to things like GBM in adults as well. So a little overview. So main points is that pediatric brainstem tumors, they're mainly classified based on their anatomical location and their appearance on MR imaging. And DIPGs tend to have the worst overall prognosis with no current role for surgery and biopsy indicated for some cases, depending on the agreement of the parents. And the rest of them are fairly low grade for the most part and have better prognosis. A lot of them can be conservatively managed, like tectal gliomas, or there can be amenable to surgical resection, like dorsal exophytic tumors and adjuvant radiation as well. So this patient was eventually sent home and will follow up, with Dr. Morgenstern in 2 weeks. I think it should be soon, the next few days. And I think the routine treatment for this patient, care for this patient, would be just follow up an MRI in 6 months, to check the patency of the ETB, check the growth, and then I think you spaced out the MRI to every year and obviously watch out for any new symptoms to keep an eye on these tumors. Okay, and thank you, everybody. It's my short presentation.
It's a nice overview, Abhi. I think the things to take away from that, particularly for the residents, especially since you're headed towards the boards, is that this anatomical classification is really what guides your surgical decision making, and then all of the pathologic subsets are what ultimately define treatment. And it's true, most of them are low grade. Really, the only category of brainstem tumor that is basically non-surgical nowadays is tectal glioma. So a bland, non-enhancing, small tumor confined to the tectum does not warrant a biopsy unless it progresses. But any atypical appearing tumor in the tectum or exophytic from the tectum or anywhere else in the brainstem is worthwhile for a biopsy, even DIPG in the modern era, because we now know that the molecular markers that go with that tumor can give a lot of information about prognosis, and in some cases can offer opportunities for clinical trials or a clinical trial eligibility for targeted therapy. Looking at the attendee list, I don't think we have any questions. So we're going to take a few-minute break because our next speaker hasn't signed on yet. So everyone can just take a breather, and we'll introduce him when he comes on.
So the plan, Peter, is that Dr. Germanos going to introduce Gary?
Yes.
All right.
Good morning. Thank you, Peter, for asking me to do this. Really appreciate it. And the slide is there and I can see it, so it's even easier. Thanks.
Great. I have to say, I didn't expect being ahead of schedule to be our problem today.
There is always a first. You're a magician. What can I say?